why don't we get started? Good afternoon, everybody. This is the Young Investigator panel. I'm Ali Fatemi from Kennedy Krieger. I'm a former young trainee myself, but unfortunately not young anymore. Have been spending most of my professional career on leukodystrophies and ALD. So this is a session to introduce new entrants of investigators into the field of adrenoleukodystrophy, and this is an ever-growing community, so it's very exciting, and I'm happy that you have joined. There is 3 people here. There are others that are not here today, but these 3 are forthcoming, I guess, so that's great. So the first one is Dr. Ramirez Alcantara. She's a pediatric endocrinology fellow at the Mass General Hospital at Harvard in Boston, and is still she's a physician already, and she's already trained in pediatrics, and now she's training further in pediatric endocrinology as a subspecialty. Each of these investigators are gonna give a 5-minute presentation followed by 5 minutes of questions, and then we're gonna move on to the next. So Jonanlis, you wanna start?
Yes. Are you able to see my screen right now?
Yeah.
All right, thank you so much for the introduction, Dr. Lee. So today I'll be presenting my research in hypogonadism in patients with XALD. So I have no disclosures, and this is the topic, the outline of my presentation. So starting with what the definition of hypogonadism is actually a condition where the ovaries and testes are not able to produce estrogen and testosterone. And if we go a little bit about the physiology, there is something that is called the hypothalamic pituitary gonadal axis, or HPG axis, where you have the pituitary gland that will produce LH and FSH, and this will increase the testosterone levels. So there has been 3 proposed mechanisms of why hypogonadism happens in ALD. So the first mechanism is that the buildup of the very long chain fatty acids will produce direct testicular damage, and this will decrease the testosterone and will produce an elevation of LH and FSH. In the 3 mechanisms, you're gonna find the same laboratory evaluations. The second mechanism is that these very long chain fatty acids interfere with the binding receptors for LH and FSH. And then the third mechanism is that you have decreased substrate, so you're gonna have like decreased cholesterol that is important for the production of testosterone. So if we talk about a little bit about the symptoms of hypogonadism, in females, you're gonna find amenorrhea, oligomenorrhea, hot flashes, and vaginal dryness, and in males, you can have erectile dysfunction and gynecomastia. In both sexes, you can have fatigue, decreased libido, and infertility. But right now, there is not much about hypogonadism out there. In the past 30 years, I was not able to find many references. One of the references is this study from 2019. This was a retrospective chart review that they focused mostly on adrenal insufficiency. They included 159 patients with a mean age of 24 years. And the only criteria for hypogonadism that they used was the patients were on testosterone replacement therapy. So the prevalence was around 2.5%. They included adult and pediatrics, and from the adult patients, that they were a total of 95, there was a patient who required fertility treatment. 35% of them had fathered children without any medical support, and 61% of them, unfortunately, they didn't have any data or had not tried to conceive children. The second study from 1997 included 49 patients with XALD AMN and 105 controls with a mean age of 36 and 33 years. They found 81% prevalence of impairment in testicular function. And when they tested LH and FSH, they found elevated in 63 and 57% of the patients. And when they compared the mean testosterone levels, even though in ALD patients were normal, when they compared with the controls, it was significantly lower. This study included 16 patients, a total of 17 patients with a mean age of 34.7 years. And they also found elevations of LH and FSH in 57 and 42% of the patients respectively with normal testosterone levels. This other study that included 26 patients with a mean age of 34 years, they did find slightly lower elevation of LH and FSH because it was only 16 and 32% of the patients, but they found low testosterone levels in 11% of the patients. And they did a testing that is called an ACG stimulation testing. That is a medicine that will bind with the LH receptor. And when you give it, it will increase your testosterone levels. So they found that 88% of the patients had insufficient increase in testosterone levels. This last study included 69 patients with XALD AMN with a mean age of 36.4 years. And they found an elevation of LH and FSH levels in 42 and 30% of the patients. And 22% of the patients had either low or borderline zero testosterone level. So right now, as you were able to see in the studies, everything is from patients, adult males. So we thought about if there are other times in life that we can identify hypogonadism. So actually, we're able to test for hypogonadism in the mini-puberty of infancy, in children of pubertal age, and of course, in adults. So in the mini-puberty of infancy is a period in the first 6 months of life where the HPG axis activates. And after 6 months, the hormones will be low until the patients reach puberty, that usually is in female between 8 and 13 years of age, and in males between 9 and 14 years of age. So when we have hypogonadism in puberty, the patients can have delayed puberty. In adults, it has been proven that estrogen and testosterone decrease over time. So like right now, there's a lot that we don't know about this topic. So what we would like to do is we want to include patients from 0 to 6 months of age, children of pubertal age, and adult patients above 18 years of age. And we want to have both female and male in our study. And what we want to do is we want to collect a blood sample, do a retrospective chart review, and administer a Persian survey to screen for symptoms. And our end goals is that this study will allow us to better determine the true prevalence of hypogonadism and whether treatment should be given earlier in the course of the disease. I would like to thank everyone who has helped me accomplish this project. Thank you so much. I think you're muted, Dr. Fatemi.
Sorry, yeah, thank you so much. Yeah, I don't see any questions yet in the chat. One quick question I had is the measurement in the blood for your study, is it time dependent? Does it have to be early morning, like in the steroid, when you do steroids, or?
Ideally, the samples, yes, all of them are gonna be early in the morning.
Okay. Okay, great. Let's move on to the next other ladies first. So maybe Isha Srivastava is a pediatric neurology trainee at Stanford Children's Hospital. Do you want to talk a little bit about what you do?
Yeah, sure. So I think I am still quite early in my career. I'm one of the I'm still in residency. I'm doing a residency in child neurology. I'm working with Dr. Keith Van Haren to look at really how metabolic dysfunction can lead to or is linked to inflammation in cerebral ALD. And so we're really interested in looking at the role of the inflammasome, which is basically a large complex that promotes a pro-inflammatory response. And so the preliminary data that we have from brain tissue samples shows that the NLRP3 inflammasome is elevated. And we also have CSF data from children with cerebral ALD that shows some of the cytokines specific to the NLRP3 inflammasome is also elevated. But the next parts of the data and my research is going to look at what that means and what's causing this inflammation. So is the inflammasome activated merely a bystander or a consequence in the larger ALD process, or is it playing a more active role in propagating the inflammation? And the next part of my research is really interested in, and I think one of the big things that I'm interested in is how do metabolic disturbances like oxidative stress or accumulations and other bioenergetic stressors cause or contribute to inflammation. And so the other parts that we'll look at is what is causing upstream of NLRP3 for the inflammasome to be activated. And unfortunately, I do not have slides presented, so I thought I would just talk through the research thus far and some of the future directions that we're looking at.
Yeah, so can you give the audience a sense about your timeline, when you think you're going to be studying this and that in relation with your own training?
Yeah, so right now, as I mentioned, I'm in my 4th year of my residency and am hoping to go back to the lab for at least 6 months or so next year during my 5th year of residency, where we will take a deeper look at the upstream modulators of the inflammasome. And then I'm hoping to continue this work during my fellowship, so after residency, where I'm looking to focus on neuroinflammation and specifically leukodystrophies.
That's great. That's great. Okay. Yeah, I see a couple of questions actually for the first speaker, but we'll come back maybe to that. And then Dr. Van Hen has a question. I'm going to come back to that as well. But let's go with Ashish first. Dr. Gupta, he's an assistant professor at the University of Minnesota, a pediatric bone marrow transplanter. Is that the right thing to say?
It's actually bone marrow transplant, so it's okay. Everybody says bone marrow transplant. So, hi, I'm Ashish. I had the privilege of meeting and working with some of the families who might be here. I am I would say the older of the young investigators, I guess, and I am PGY 11, I guess now. So my introduction to ALD was about 4 years ago when I came to Minnesota to do a fellowship in pediatric blood and marrow transplant. And it has been just a fascinating journey since then. I started working with Dr. Paul Orchard, and Dr. Westmiller was here that time, and Troy, and the amount of stuff I have learned in the last few years has been amazing, and it just baffles what this disease is about. My focus is on inherited metabolic disorders, the transplant and gene therapy for those disorders. So I come from the treatment standpoint. And ALD definitely is one of the main disorders that we focus on and we transplant. So in the last few years, what I have worked on includes, on the clinical side, we have developed our comprehensive ALD clinic, like other places, where we have transplant as one of the major subspecialties, where we see the families up front and do prepare for a lot of stuff up front in terms of transplant, and we follow them longitudinally, and we kind of like coordinate with other subspecialties, and it's kind of like yearly or like twice a year visit to the clinics, and it is not limited to just patients in Minnesota. We have actually families coming from all over the country to the clinic. It's been more than 2 years now that we started this clinic, and we are just growing quite a bit there. Another feature of the clinic is that we have integrated some of the early studies in the clinic, research studies, which include the neurocognitive testing, imaging-based research, and definitely one of the main interests is to see the boys, or identify the factors that can look into the boys who develop the cerebral form of the disease eventually. So also in this clinic, we offer what we developed as an ALD national registry study, which is, as I think all the stalwarts in the field recognize the need for, and we have been able to establish that and develop that in the last few years. All the kids that are seen in our comprehensive ALD clinic are on this study, but the goal of the study is to actually enroll everyone remotely. So, which was a plan even before COVID started. So we have not stopped this study since COVID, and we continue to enroll on this study. What it entails is we do the online consent and everything on the study, including the online surveys, abstraction of medical data, imaging, and actually even the biospecimen procurement. Everything is done remotely. So for the kids who we see in our clinic, we can get the specimens here, but if there's a family in Texas, we can send the shipping kit and we can get the samples from them. And like there is a lot of coordination that happens behind the scenes, but we have been able to establish that. And I want to thank all the families who have enthusiastically participated in this study. We have more than 150 participants on this study right now, which is very, very encouraging for us. Another area of research that, like from the treatment standpoint, that we are focused on is to reduce the toxicity of the agents that we are using in our transplant and gene therapy. We do what is called as the pharmacokinetic monitoring of some of these agents to find the right dose for each patient. And again, this is an ongoing project in collaboration with UCSF. And the goal is to have the maximum efficacy with least toxicity. So a lot is happening on that side. And you guys heard Dr. Lund this morning, focusing on treatment for patients with advanced disease as well. So those are some of the areas that we have been working on.
That's fantastic.
Thank you.
Thank you. So we have a few minutes left. I think there's still a couple of things we would like to discuss. There's some questions coming from the audience. One is a quick one. Is the hypogonadism study enrolling?
Not yet, but I'm sure, hopefully the next few months we're going to be starting enrolling.
Okay, great. I think some of the other questions can be directed to other sessions. One of the main questions, I think, and that's from Dr. Van Haren, is what I asked you earlier, is why are you interested in ALD in the first place, and where do you see sort of your long-term goals there? Isha already talked about, going back to the lab, and I think I heard some from Ashish as well, but how about you, Jonanlis?
So I got interested in ALD after I heard a presentation done to my group by Dr. Packard, and after that I started researching about what areas we can contribute in the chronology part. So after that I just got to marvel about the things that we can contribute. And regarding this research study, something that I would really like to contribute is the first thing is actually be able to figure out what the true prevalence of hypogonadism, and also because since we're testing patients so early, like we want to test this patient in the first 6 months of life, we'll be able to know if these patients may have some issues like entering into puberty, and we're not just going to be waiting to see if puberty happens and if they're going to need some extra treatment at that time.
Any comments about why you're into ALD for the other two speakers?
Sure, I can definitely go ahead. I think my eventual goal is maybe one day you guys don't need us. That is a cancer care model that I was trained in as a pediatric hem-onc fellow. I think again, like therapeutic developments in this area are definitely getting better and better. But hopefully, in my lifetime, as I talked to Eric about it, maybe one day, like we might have much better therapies, and if the kids are picked up early and we have effective therapies for that less score and that amount of disease, hopefully you guys don't need us.
Yeah, and I can talk a little bit about, I guess, what specifically got me interested in ALD. And one of the things that really, I guess, was interesting and intriguing was that we know that there is this mutation and we know that there is inflammation, but how the mutations in ALD and the known metabolic, I guess, dysfunction or imbalance, kind of how those two are connected, and really interested in learning how some children with ALD, with these lesions in the brain, how they stay stagnant for some time, and why some children's lesions go on to progress and become much, much worse, and how the inflammation progresses too. So what is that trigger, if there is one, and what causes that tipping point to happen?
One question I had is whether the pandemic has had any effect on your own goals. I know, remembering from my days, that every day matters when you're in early stages of career. So losing out several months of research must be impeding on what you're trying to achieve. So can you guys comment if it has had a major effect or not on your work, on your progress?
I think, at least in my perspective, it has not affected that much, because like most of the things we have been able to do, at least remotely. It was a little bit challenging when we were trying, when we were designing the protocol, like how we're gonna obtain the consents. So we kind of try to we're gonna try to do a lot of whatever we can also remotely.
So for us, I mean, for the registry study, it was on during the whole process, so we didn't have a setback there. And from the treatment standpoint, I think everybody understands that timing is the key here. So we were not closed at all. We do not have the privilege to be closed. So we continue to transplant the boys. Gene therapy trial was a little bit halted, but again, we are back enrolling the boys on the trial. So I think from our perspective, we were still on.
I think long-term, probably not, since I'm still in training and still in the clinical aspect of it. So have very discrete periods of time to go back into the lab, which fortunately my schedule allows to change around and accommodate the shelter in place and the quarantine restrictions. I think on a larger realm, having to do a lot of the conferences and collaborations virtually, even lab meetings virtually, which is just a different feel for someone like me who's still growing and learning. They're different. I'm glad we're still able to make connections virtually. Obviously, would love to do it in person much more.
Okay. So there's a comment saying patients want to help. Is there anything ALD community can do to help support, promote these investigators' efforts? Important question, I think.
I can.
Well, I think that sorry, Ashish, you can go ahead. So at least from our perspective, when we start recruiting patients, it will be great if we can get at least if ALD can help us promote the study so we can get more enrollment. And also especially the babies in the first 6 months of life, those are a category of patients that we really want to try to catch.
Mm-hmm. Mm-hmm.
One thing I would definitely mention is that all the support that we get from the families is a big driving force for us. Also, your feedback, as I said, is very, very, very important. I remember 2 years ago when we first started the ALD registry study, many of you guys, I have talked to many families now, and you guys had such amazing feedback. It really helps us grow and understand and try to comprehend the field and where you guys are coming from much, much better. The family's perspective is always, always so critical. We have these amazing people who are guiding us in this ALD path. But at the same time, I think if you guys support and give us your feedback, that is always very helpful.
Great. All right, well, we got 2 more minutes, so maybe we address one last question here, and that is, any advice for young investigators just starting out?
I'm starting out. I think having a great mentor and having a great support in your area is very important for getting your projects through.
Yeah, and I would second that and also add that it's never too early or too late to get involved. And if something is interesting, I would say don't hesitate to reach out to all the people here and probably lots of investigators and interested parties at the various institutions. I think everyone is more than willing to help, and it's a really collaborative community.
They both stole my words. I don't have anything else to say.
Great. Well, that's perfect. So we got 1 minute to the next session, which starts at 3:10. So I guess it's 3:15, but we're supposed to be done at 3:10. So thank you all for telling us your story. This is great. And hang in there. Keep up the good work. Thank you all.
Thank you, Dr. Fatemi.
Thank you.
Thank you.